Takže buď se bráníš jako rovný.
Herkese günaydın. I would like to say welcome and good morning to all. Really great pleasure to see all of you here to the first simulation, and it's really fantastic time. I hope you will enjoy from this meeting, and of course we should start early because we have a really tough program. So important for us to make this training facilities real, because we performed to make the real scientific-based training models. These models will be used by you, by medical students, urologists, some residents, by all of us on Saturday. So this part is the theoretical part of the meeting, and we will start the practical session on Saturday. It means that please do not hesitate to interrupt us, because this is not really a friendship congress, not the friendship meetings, not the congress, but the project meeting. So I would like to especially focus some points related to the learning, training, teaching activities. I especially write in English and Turkish. It means that the meeting will be in English and Turkish. The talks will be in English, but you can ask in Turkish, and you can also ask in English, and both, and we can translate it, no problem. First of all, this is the basic training. The basic training of the learning, training, teaching activity means that think basic and just learn easily, not complex. So all speakers will contact to you easily fashion, and we will do our presentations like basic fashions. All training materials were produced by project team, and it means that this is research and development process. It is not so professional, but we hope that it will be professional and really for the future, because this is the research facility. And this is the second point I would like to stress out. Mainly focused on surgical techniques in urology, in general surgery, in theoretical parts, and also in practical parts. So today and tomorrow, you will mostly learn about some technical issues, okay? Not so deeply in clinical manner. This is the important for us. We will explain the practical surgical types, and on Saturday we will start to make the surgeries in 3D printed models on virtual reality models for you. The meeting language, as I want to remember again, in English and Turkish, so do not hesitate to interrupt immediately for your question. The meeting style is interactive, okay? Not we are talking, you are listening. Everybody can talk, of course, according to the manner. All training sessions will be evaluated by instructors and will be published academically. We are reporting this all facility, and we are recording the theoretical lessons, and you will watch in our website, of project website. And also, you have now a file. In this file, in your file, you have two forms. The first form, for you will fill in, okay, about the meeting quality. The second part is for us as instructor, and during our practical sessions, we will fill it according to your level of expertise during the surgery, okay? This is very important for us to get these two forms from you. And I really request you to fill the forms at the end of the meeting. So this meeting has some legal issues because of the legal issue of the European Union project system. So this is maybe I'm proud of to be here with you the first time, especially in our section, in urological and surgical section, to do an European Union project meeting with you, with your participation. I would like to thank again Professor Dr. Moon and Professor Alberto Paoluzzi and valuable colleagues from Italy, and our colleagues from Czech Republic and Lada, and our colleagues and Jean and Miroslav, and also probably he will participate, Marinos Berdebes from Greece. He will join us, and of course our Turkish colleagues. We are making this project real. And for just a second, I would like to invite Professor Dr. Moon to share his fields with you. Professor Moon, please. And then we will start the first session.
Hello, good morning. Merhaba, günaydın, and buongiorno. Yes, I really appreciate it. So I'm orthopedic surgeon. Fortunately, I can join this meeting because I produce virtual reality material together with Dr. Yuri. After that, we can produce very valuable product for our future training, and finally we are going to real augmented reality. Let's go together. Thank you.
Okay, and now the first issue regarding the project, I would like to present the topic on the future of medical training using 3D printed technology. So actually, everybody knows about the traditional training methods in our clinical manner. And we are using some biomodels. We are using some physical simulators. And you can see the type of the biomodels and the physical simulators in the medical training, and also the upper level of the medical training. And we can use the plastinated cadaver model, virtual reality model, and some commercial models, and also the physical simulators. But when you look at the big picture, these have some lack of the pathology, and sometimes the expenses are a problem for us. And of course, we have some tactile feedback related to the models. And of course, the other important issue, to provide the real anatomy. The anatomical, this efficiency is another problem. Everybody knows that. The practical experience in our daily life for residents, for students, and related to in vivo training. But we have some limited regarding the practical experience. on the logistics and the patient risks, especially we are afraid of the complications from the patient, and the workout restrictions and the minimizing the procedures time. Because we are a surgeon, we should do the fast surgery. At this time, we can skip the training evaluation and the residence training. However, scarcity of the uncommon procedures and the stepwise training is sometimes lacking. And as a residence cannot complete the whole procedures only in a one time. For this reason, we think that we should find the need for the training. So you can see this girl, she is alone in the room, but only has an eyeglasses. And just think about what she is thinking on when she look at the eyeglasses. Where do you stay? What do you think? And what do you see? Of course, if you consider the image in the eyeglasses, now we propose 3 items regarding to seeing the 3D printing. The first solution can be the 3D simulation. But when you think about this both issue, the 3D printing and the 3D simulation, and based on the virtual reality and augmented reality, we have 3D bio computer aided design model. So this is important for us. And this, if we have this model, we can create a 3D printing model and we can create a 3D simulation model. It means that the basement is the BioCAD model, computer aided design. This is our first issue, but for why? This is one literature regarding the urological section, but this report shows us the top 3 reasons for 3D printing in urology: improving the patient education, enhancing the surgical training, and conferring the superior clinical outcomes. At the end of the day, we have to help our patients with the low cost and the low morbidity. What is the 3D printing if we want to start with the 3D printing technology? And 3D printing technology is copying the models. The models is the virtual models. The copying models can be done by additive manufacturing. It is to make the layer and by layer with the XYZ, the 3 fashion, processing of joining materials to make an object from 3D model data with the layer by layer process. So when you think about that, it is easy or not, but this is we have really professional machines to make it. A manufacturing method in which objects are made by fusing or depositing materials. And we can use the plastic, metal, ceramics and powders and everything else and the hydrogel. But the most important issue, when we think about the training-based 3D printing, we should select appropriate materials. So we have to try some materials if it is possible, if it is suitable or not. So we, at the end of the day, we are creating the 3D printing model. This research article, I like it very much. This shared by Professor Banu Onaral, and really great article shows us the lack of the 3D printing technology and the efficiency of that also. It includes 31 research articles related. You can see that here, and we can use the 3D models as biomodels. These are static biomodels. It's like organs, you know, the real organ. And the second type is the physical simulators for diagnosis and for treatment. However, it means that we can use the 3D printed models as a biomodel. We can print, and we can, thank you, Dr. Moon, and we can print the organs, only the organ, without any physical action, especially as it means that it's called the static biomodel, the terminological. If we can do some application like we are going to make it in Saturday, it calls as a physical simulator. This article shows us the 2 types of the usage of the 3D printed models. And in the literature, especially the oncology, ophthalmology, and some another disciplines, include the static biomodels. However, when you look at the physical simulators, it's especially based on some procedures. Sometimes the procedures can be complicated procedures. Sometimes, especially, you can see it depends on the difficult anatomic sections, like neuroanatomy. you see the neurosurgery. The neurosurgeons are mostly used in the 3D printing technology in our area. But as a urologist, we started to use it. Why? Because we are using the technology. We really using the most of the procedures, more than the 90% is endoscopic surgery. So we needed to use it, the 3D printing technology. But when you look at the research articles, we are still growing on this topic. For the 3D printer uses instructions, a digital file, the BioCAD file, to create a physical object. And we have a CT MRI in our daily life. Everybody can use this CT or MRI. And these files has a DICOM, you know, the digital imaging and communications in medicine. And all series are the DICOM. If you have some CT or MRI, you can really get only the files of the DICOM. And when you have a DICOM series, you need the segmentation, first of all. The segment organ, for example, if you start to use the kidney, you segment the only kidney from the other part. So it means that you should know the anatomy, you should know some radiological knowledge. However, after segmentation, editing and repairing. And of course, the segmentation is important, but we have some artifacts. Tomorrow, however, from Mimics Materialize, they will give us a really theoretical lesson about that. The segmentation and the repairing is important. This is, I think, the important, the STL files. If you have an STL files, the 3D polygonal mesh, you can transfer these STL files into the 3D printing or into the 3D simulation or for the virtual reality models. However, what are the benefits for the 3D printing? The benefits, this is reported some articles. It decreases the cost. It can change from various rates, and using the technology and printed materials for better understanding 3D surgical anatomy. Because we believe that if you know the anatomy, you can be a better surgeon. You can learn easily than especially for the complex cases. Creating the 3D printed medical models for dry lab training, you will also see during this project meeting. And if you have on STL files, for example, our professor, our colleagues provide us really complex cases. The multi-renal tumor, for example, and this really exceptional case, we can secure the STL files for the training session or for surgical planning, so it can be the reusable material. However, important is the Professor Moon will explain more detail, standardization. Okay, we are printing everything or more the organs, but the standardization is very important for us. So for IEEE SA Standard Association, especially with the chair of the Professor Moon, we are working to make the standards in the world. However, another advantages of 3D printed models for resident training program, for medical student training program, ability to complete entire procedure, and however, because of the really workout restrictions, and you know the pressure to reduce OR cost, OR time, and minimize the risk to patients, and repetitively, you can do your training session is what many times, okay? It's important, and you can use it many times, and enlarging this specimen if you want to learn more anatomy. This is one of the 3D modeling. I would like to especially stress that without 3D modeling, it is impossible to go forward with 3D printing or for 3D simulation. Look at, please, this is for one of my patients, only the bone structure. From the 1980s, am I right, Professor Moon? Because it started with orthopedic surgeons, and they used this 3D modeling for bone structure. Because a little bit easy when you look at the bone, because of its Hounsfield unit, you can segment and you can structure the bone structure from the solid organ. It's easy. But when you look at the solid organs like kidney, like liver, like spleen, it's a little bit, it has some difficulties. But only you can see there is a left stone, and it's like a bone, and we can show that in the 3D modeling, stone is here. So it means that it means that it's controversial point to differentiate the stone and the kidney during the 3D modeling. However, this is the brief summary of the 3D modeling process. Two-dimension segmentation, okay, it's not enough for us. Three-dimensional segmentation, it includes also volume rendering and texturing. We have a right kidney model, left kidney model, and at the end of the day, this is the virtual models and 3D printed models. And of course, this is the basic information about how we are doing the 3D printing. On the other hand, for the 3D printing model, as I mentioned before, you can use as the printed model, and you can use also for the surgical planning. You can see this is the kidney, and also the tumor is located at the anterior, posterior part of the kidney. And so we printed this kidney also for the training purposes. On the other hand, for the surgical planning, you can see the usage of the mimics materialize here, and for the segmentation of the one of the complex case, the vesicovaginal fistula, and so we can succeed to make the pre-operative surgical planning for these aims. However, my last slice will be related to our project, a little bit give some brief information on that. You can see, I would like to introduce, this is the funded by the Turkish National Agency, co-funded by the Erasmus Plus program of the European Union, with the collaboration of the 5 countries. And you can see the management table of the project. So it lasts 2 years. And the aim of the project is to create novelty in medical training and novelty in technology. And so, because of us, probably, we select the urology and the general surgery on how we can go forward on that. And this is the first European hub for medical 3D modeling, and to create improvement learning technology method for these purposes, and creating innovative model. And during the project, we aim extraction and reconstruction of the 3D realistic anatomical models. We used our patient data and the patient data of our colleagues, okay, CT or MRI, and these models used for printing technology and also the virtual reality technology. So it means that we have some standards for the models that you will see on Saturday, and how we created the models. Of course, the target groups are here, and we expect to increase the number, but of course, some examination and some reasons of the medical students are important for us, and also residents and some specialists. But the important issue related to project, during the project we are making the training, okay, but also we are making the research. And the research facility provide us enthusiasm to make the project real. We have 4 intellectual outputs. This is a little bit more than half of the project. And we are here now, intellectual output 4. It means that we completed these 3, and we are now proud to share with you. We prepared everything, every model, for 11 stations, more than 50 piece 3D printing and the VR models. And so it means that this is a really big teamwork. I also thank you for all project partners. And however, they have 11 stations. These 11 stations include 2 general surgery and the 9 urological section. And each participants, I would like to inform you about what will you do on Saturday. Each participants will perform each station training procedures. Not an hour, not an 2 hours, because we will evaluate your training objectively. The second item, training and 3D models evaluation form, will be filled by participants, and the training evaluation form will be filled by instructors. And of course, we have a section of the anatomy, Professor İlkan Tatar, and we have a delay for his slides. But because of the evaluation of the anatomy, we will have a pre-test for you, and just maybe 10 very easy questions. You will fill the form, and at the end of the meeting, you will also fill the form to evaluate the efficacy of the training based on the anatomy. The first station related standard 3D printed anatomic urinary system model. And really, we will do this surgical procedures on 3D printed technology models. I would like to show some video. This is our VR model, but it's not enough for us. We converted this model into the 3D printed model. This is our only experimental try. And the second station will be related 3D printed bladder and prostate model. We will resect the prostate, and we will do the resection of the prostate with a real 3D printed model. And you can see also here how you will do it. And also, you know, for the medical students, it will be interesting for you because we know that our rounds, you are only observing these procedures. Am I right? But in this training, and you will do real surgical procedures, and you will feel all materials and all equipments for surgical techniques. The third station will be related to kidney and the vascular model. So we have one training box, laparoscopic training box, and laparoscopic surgery will be done by you also. The fourth will be related to anti-incontinence surgery for female, and the fifth set prostate biomodel. Günay Akdoğan from Medtronic, he did a very good biomodel for us. You can do the prostate digital rectal examination for the 3D printed version. Good morning, Marinos. Welcome. His colleagues from Greece. And the last set will be sacral neuromodulation. I would like to stress that we are, as a urologist, a little bit far away from the sacral neurostimulation, but you can see the technique, and you can see also the models, how we can use it. And I would like to show, this is the brief information, and it's written in the form. And also we have 3 VR simulators, and really the really great job of Professor Moon, and he used our data, the patient data, to make the VR models real. Everybody will try it, but not only try, we will evaluate your efficacy. However, this is the section of our colleagues from Czech Republic. They will probably, their presentation, they will give more information about the training models for the general surgery. And I left this part to you. Please, you will inform more. This is our first learning, training, teaching activity. Of course, we have two, and the second one will be in Italy, in Rome, with the head of the Professor Alberto Polozzi, Professor Cesanti, and the colleagues. And the third one will be in Athens, with the head of the Professor Andreas Skolerikos and Dr. Marinos Berdebes. So this is important for us. We hope everybody we can go to there, okay? Especially I'm inviting all of my medical students to also some residents. And however, we have a congress in 2018 in Antioquia, in Hatay. We will inform you more detail about that. We have a club. This is the club. Probably now we increased more 300 or 400, but we have more than 4,000 visitors for our webpage. We are in social media, in Facebook, on Twitter, everybody, and we have some potential collaborators. And we are a team, and we want to be a big team with you. I would like to thank you for patience. I'm open to your questions. Thank you so much.
Any question from the audience?
In Turkish or English?
Yes. Any question? My question as a orthopedic doctor to Dr. Yuri is, it is very tough for produce 3D modeling. As you told me before, the body is clearly demarcated by the hospital. The difference.
Yes.
However, the structure is very tiny.
Yes.
Also, it's very hard to define in between each boundary system. So, do you have any special skill for obtaining very fine material like yours?
Yes, Dr. Moon, I think these are very good questions. Why? Because when you compare the bone and the other structures, because the bone is different from in the body. For solid organs, you can see for everything, but I am just only can reply on urology basis. Especially, I think the 3D printing the first of all, to manage the real 3 millimeter section, CT or MRI, is very important. Sometimes it's different, but for prostate, especially because we are doing some diffusion prostate MRI. For prostate MRI, we are using the 3 millimeter. It's acceptable for the patient, but for CT, it's very difficult. But we are using some cadaver specimen. On cadaver, you can make some really thin layer segmentation. However, after 3D printing, if you will use it for physical simulator, we are making some processing. Not only 3D printing, is okay, but processing, during the processing, of course, we have some difficulties because we are using flexible ureterorenoscope, flexible cystoscope, we are indwelling the catheter. So we can change some diameter, we are not destroy the real structure, but only we are enlarge the model. But the anatomy is the same, but enlarge the model. At the end of the procedure, you can see the real and enlarged model. So this is really more than a year, my experience for more than 50 pieces 3D printing urological models.
This is my goal too. Yes.
Thank you so much.
Question from the audience. Turkish is also okay. Can you? Thank you, Professor.
We have a little bit small change because Dr. Mustafa is preparing his topic. Dr. From Czech Republic, Dr. Lada Edarlova, I really request you because of some arrangement, if you are ready, of course. She will talk on review of crucial anatomical structures of hepatopancreato-biliary system with relation to operation planning.
This one or this one? Mobile.
Well, good morning, everybody. My name is Lada Eberlova. I'm a member of team from Pilsen. Of course, we would love to thank for the invitation. It's our big pleasure, honor to be here and share our knowledge and experience. I am actually a teacher of anatomy at the medical faculty, and I'm here to introduce you. For some of you, hopefully, revise the general anatomy of the liver, biliary pathways, pancreas, and the information I'm going to offer here are going to be used later with the more practical contributions by my colleagues. Let me introduce Dr. Jan Bruha and Dr. Miroslav Jiřík. We will share and meet you later within the program. So our big pleasure to continue what's going to be said by me in the theory. Let me ask at the very beginning, are there any pre-graduate students? Could you please put your hand up? Like just one. And postgraduates, probably more. Is there any postgraduate student here? No? Okay, so just the physicians. Okay, so this is the town we come from. We are from Pilsen. You might know the brewery, the beer, also the Škoda cars. So these are not produced in Pilsen. This is our department of anatomy, the building, the medical faculty, and the historical center. So Pilsen is not only the industrial city. It has about 200,000 inhabitants, and the Czech Republic, if just to show, is in the middle of Europe. Probably you know this. So how is it with the liver and gross anatomy and surgery? So what I'm going to revise here is the basic theory every surgeon needs for the liver surgery, which is mainly the liver resections and transplantations. So for this, we need to know how is it with the liver fixation to mobilize the organ. And so you probably know that the liver is fixed by the porta veins to the inferior vena cava, but also by peritoneum. Some of these structures are duplications, some of them are just the unilayer sheath, and of course for the resections we need to know the liver segmentation. So it's the biggest gland. This organ is the biggest gland in the human body. It's also compared to the metabolic factory, so it's very tough to summarize. But basically, it's metabolic activities. It takes part in hemostasis, in of course nutrition, but also in immunodefense and hematopoiesis, which is very important in case of pathological processes. We describe the diaphragmatic surface. Of course, the liver is the most of the parenchyma is covered by the right diaphragm in the right hypochondriac region, and then part of the organ crosses the midline to the left hypochondrium. Macroscopically, we describe the diaphragmatic and the visceral surface that's visible when we turn or look from below or turn the liver over, having the specimen. And from this point of view, from the macro anatomy, we describe four lobes, the right and left, that are bordered with this structure formed by peritoneum, that's the falciform ligaments, and from below we can see they look quite small, the caudate and quadrate lobes. So here, of course, in the visceral surface there is the hilum where enter the trias, the hepatic trias, that comprises the porta vein, hepatic artery proper, and biliary pathways. So for lobes from the macro point of view, but for the liver resections, these do not work actually. We need to follow, to understand the segmentation, we need to follow the vascular branching. So for the organ, also the connective tissue is very important. So most of the organ is covered with the serosa. The area that is not, we see it bordered here, is called the bare area. And under the peritoneum, and here, if it's not here, there is a connective tissue we call the Gleason fascia that accompanies the vessels to the depth of the parenchyma. So here's a revision how the hangings of organs in abdomen develop. The primitive gut protrudes from the dorsum and pulls in front the coelomic membrane, which is in the end, in the abdomen, the visceral serosa, but of course the same histological structure and similar development occurs with the pleural or pericardial cavity. So this is just to show that we have double sheaths of peritoneum in abdomen. Of course, the best example of it is mesentery or mesocolon. Many times they have prefix mes. And here is the root, and here at the organ there is where the continues the parietal with the visceral sheath. So to show it here, and here we are at the peritoneal attachments, what we could have seen on the former slide, and we will see later on. So the parietal peritoneum continues onto the viscera and forms the unilayer. There we can palpate when we put the hand under the diaphragm. So that's the coronary ligament. When we cut it, it has this anterior and posterior part. At the hilum we have the duplication, that's the lesser omentum. At the free edge there is the hepatoduodenal ligament where the glissontrias runs, and behind the stomach here we can see a peritoneal space that is important for the approach to the pancreas, which is a retroperitoneal organ. We can see here that's called lesser sac. If we look at the same, what I'm saying a bit theoretically, so from in front, the visceral surface, the peritoneum forms the falciform ligament. At the free edge runs the round ligament, the obliterated hepatic vein, obliterated umbilical vein. Here is the coronary ligament as the unilayer. And here, where meet the two coronary ligaments, there is the triangular ligament. When we remove the liver from abdomen, we can see border like this, which shows the striped line shows the peritoneum, and the surface that is adhered to the liver, the diaphragm adhered to the liver, shows the bare area. Here is the inferior vena cava with the inputs of the hepatic veins. So that's the fixation. These structures need to be cut to make the liver mobile, either for the resections or the transplantations. A bit more about the hepatoduodenal ligament, which is a very, very important structure. I've already mentioned it's at the free edge of the lesser omentum, borders the entrance into the lesser sac, also called the omental bursa. And here runs the trias. So what we show to our students within the trias behind the thumb imitates the portal vein, which is of course definitely the thickest of the three structures. And then there is the hepatic artery proper in front medially, and biliary pathways that are formed by the two hepatic ducts and fed on the common and bile duct. So that's the hepatoduodenal ligament from above. Of course, that's the axial or frontal section. This is the organ as its own, the prosected specimen with the structure I've just named. Here is the hilum, and I would like to show the difference between the anatomical division, which is here, formed by between the right and left lobe. The border is formed by the falciform ligament. And if I show here, that's the same line, that's the anatomical border between the right and left hemiliver, and here is the surgical border. So awareing how many varieties there are, still the hemiliver are bordered from the surgical point of view by first order branches of the portal vein, which of course develops by the confluence of the splenic and superior mesenteric and runs fed on within the previously mentioned hepatoduodenal ligament. So that's the right and left hemiliver. But as it has been mentioned, there are at the end of the liver circulation there are three hepatic veins. And to understand the circulation, we need to go a bit into the histology, which is going to be very brief. But let me just show, this is very important for understanding the liver segmentation. So here I've chosen the slide to show how the hepatic artery proper originates. Of course, it's from the celiac trunk, and actually before from the common hepatic artery. Here is the portal vein, again formed by the confluence of the superior mesenteric and splenic. And portal vein is called portal because there are two subsequent subsequent microcapillary networks, first within the bowel and secondly within the liver. So these structures are called portal circulation. So here we have how the liver is segmented, or the segmentation by Quinault. As a French surgeon found out that thanks to the course, or owing to the course of the three hepatic veins, the liver can be divided into 4 sectors. On the right side there is the posterior anterior sector, on the left heavy liver there is the medial and lateral, so it reminds of the fist. So I find it quite useful, helps to understand. So these are the sectors, and via the branches of the porta vein that run horizontally, these sectors are divided into the segments. In total, there are 8 segments. To remember them, they are numbered in a clockwise order, and there are some techniques like how to remember. For example, segment 1 encloses the caudate lobe, segment for the segment 1 the caudate, segment 4 the quadrate lobe. So that's the same. So if we sum it up, the rest, the right hemiliver comprises the segments from 5 to 8, the left hemiliver the segment 2 and 3. This is why the Quinault, there are many classifications, many other of the segments, but this is what is used in Europe, also not only by surgeons, but also by radiodiagnostics. And this is the microanatomy, which is essential, of course, not only for interdisciplinary approach, but for understanding how the liver works, how the bile is produced. So just very briefly, so all of you probably, those who have medical skills, medical education, remember the hepatocytes, but of course there are many other cells. They are arranged into rows in the basic, again, morphological unit does not correspond to the functional unit. So the morphological unit is a kind of polygon. In the center there is the very beginning of the hepatic vein, that's called the central vein. Here are the interlobular spaces with the triplets. We have met already these in the hepatoduodenal ligament. So that's the bile duct, interlobular branch of the porta vein and of the hepatic artery. And the vessels, the blood vessels, open into the spaces between the hepatocytes to enter the very special, very permeable sinusoids. And this is how the blood that gets into the liver meets with the hepatocytes. So it's either metabolized and then it ends in the central vein, which is the very beginning again of the hepatic veins that end in the inferior vena cava, or the bile is produced. The very beginning of the bile pathways is between, these are the fissures. The microcapillaries, they do not have their particular wall. It's just the fissure between the two hepatocytes. Of course, the bile flows out of the liver toward the small intestine, duodenum in particular. So this is, it's a big topic for histologists, pathologists, the cells, Kupffer cells, Ithos cells, other cells, but hepatocytes for what's going to be next about or within our contribution. So except for the liver lobules, the pathologists use the liver acinus according to Rappaport, or the portal lobule, which is not an object of our interest for now. So just very briefly, the biliary pathways can be described from the micro view or intraparenchymous, we call them intrahepatic, and then the extrahepatic, which is going to be demonstrated with some cases by my colleagues. So the right and left hepatic lobe join into the common. And then if there is contents inside the duodenum, the bile flows into it. If not, there is a constrictor, so it's stored, it flows backwards into the gallbladder. And it's also clinically very important that pancreas, that's found here within the duodenal window, both these organs are covered from in front by the parietal peritoneum. So this duct usually, again, there are varieties, but usually opens at the duodenal papilla, the major one, with the pancreatic duct. So the pancreas has two ducts. This scheme doesn't show the lesser duct, but the major opens here with a bile duct. I would like to introduce you at the very end what we do at our department, what we specialize on is the corrosion casting. So I brought one of the corrosion casts, so the liver, so within the practical session on Saturday, you are very welcome to come. I will show you and introduce you the methods, and I have particular corrosion cast of it's the porcine, the pig liver I brought with us. So these are the results from the casts we make. These can be more, of course, investigated by CT scans. For example, we use special resin, which is radio opaque. So this is from the macro CT, the common human CT. And these are pictures from the micro CT. Here we can see, for example, one of the portosystemic shunt. Again, these pictures were taken from the cast we obtained from the pig liver. This is the same specimens in the electron microscopy. If you were interested, here are our publications from 2016 and 17. And so much for now, and you are very welcome to join us on Saturday.
It's very brilliant presentation. Any questions? Please.
Microphone.
I want to make a small contribution to your teaching. We have some opportunities in our country with by using robotic surgery for the teaching of medical students during their education. Since robotic surgery has gained acceleration in the latest years worldwide, in our country we have the opportunity to use this issue. I want to say that is there any opportunity in your country for medical students to observe directly the three-dimensional operational imaging during their education in your country?
Sorry. Well, you can hear me, can't you? Oh, it's better. My fault. I would say we have, if I count correctly, 6 medical faculties in the Czech Republic. So each faculty has its own system. So let me speak about our medical faculty. We have 3 semesters, 2 of the gross general anatomy. The third is for the topographical anatomy, which is more oriented to the clinical practice. So yes, we use it, but not that much as it could be. And also, but what is very useful for the students, we have a dissection course. So they have the entire body available, and they start from the superficial surgery or superficial regions, and then they go to the depth. So they can see it on their own, and then in their first grade they have the radio anatomy.
Yes, ma'am. Any question? No, one more question, please.
Actually, I want to ask a question about your presentation. My name is Cem Kabuyuka from Hacettepe University. I want to ask a question about your presentation, but I don't need to look at it.
Okay.
There were a surgical and anatomical border of the liver. I didn't quite understand what are the differences and importance of these borders for us in operations or our medical life. What are their importance?
Yeah. So I understand because it needs personal experience. So as we work, of course, with the cadavers, you would not get this experience with the what is available as anatomy. But if you, and we have a surgeon here, if you cut what you see macroscopically, it does not correspond, it does not correspond what's inside. So it would bleed, or you would lose much more tissue than, so it's more selective. And so the idea is to optimize what you cut. And that's why, the idea is that what you see from, with the naked eye does not correspond to how the parenchyma is organized, and what you can cut to do the section as much optimal as it only could be.
Fortunately, I had the chance to watch your lab in prison, so my impression was so exciting. So my question is, you have great data and great experience in technology for something reading material, watching the data.
Yeah.
So can you open this paper to some accessible researchers who is interested in technology or developing some similar work or collaborate together with your present
Well, I don't think I'm a person who, is, if I'm a common teacher. So for this, for opening whatever, you would have to ask the person who is responsible for the department and etc. Is probably, even Václav is not, you need to go to the head of the projects, etc. What I can share is the method of corrosion casting, which is, I can say, it sounds probably proud, but we have shared the casts with other groups, other teams in Belgium. They are very good at it. So the filling and the quality is very, very good. So that's why it shows, it offers what we have, what we got. It offers to see the microanatomy from 3D much more detailed than it was possible so far. So for the corrosion cast, you are welcome. I can share. Can say what more.
Thank you very much. Really interesting and full academic presentation. I just want to ask about corrosion cast, because we have really different participants on different levels. We have different. So corrosion cast, how you are harvesting corrosion cast as an anatomist, in which methodology you are using corrosion cast in your daily practice for the medical students?
Just briefly, because it's very specific.
Yes, of course.
And then
basically,
you are very welcome. We can go to details. And again, we have published our experience, both with according to teaching and the methodology. It's here. So basically, what it offers. So here are the publications. You can Google it very easily. So what it is about? We get an organ And that's why we work with a pig liver, because the size corresponds to the human organ. And so you need to get the organ that is free of blood. So that makes it really, really tricky. And so the two human corrosion, fully filled human corrosion cars are owned by Ghent University, because the quality of the organ is almost as it is used for the transplantation. So they have the human liver filled with those that were excluded from the transplantation program. So basically, we get the organ, we how to say, it's out of the blood, and we inject resin into the system. We work with different colors so that you can, with the naked eye, distinguish what's the portal, what's the arterial, what's the biliary system. And so there is the input via the hepatic artery portal vein, and once it appears, the resin appears in the inferior vena cava. We can see that it's clamped at the input and output, and we let the resin polymerase the next day. And then the organ is put into the potassium hydroxide to remove the soft tissue. So what I have here in the bag, shopping bag, is pure, it's pure resin. But when you look at it, it looks like a real organ. It's so dense, the vasculature is so dense that it's really surprising.
Okay, thank you. And we will have the next talk from the other session, Dr. Paula Karakat. He will talk about the really technological topic on urological section, indications and tips and tricks of endoscopic applications in lower and upper urinary tract systems.
Good morning. My name is Tolga Karakan from Ankara Training and Research Hospital. I will talk about the tips and tricks of cystoscopy and ureteroscopy. The indications for the cystoscopy is gross and microscopic hematuria, recurrent urinary tract infections, trauma, especially intraoperative traumas, obstructive voiding symptoms, irritative voiding symptoms, dysuria, atypical cytologies, known history of bladder cancer, incontinence, urethral stricture disease, hematospermia, bladder stones, removal of foreign bodies, bladder abnormalities on imaging studies. While preparing for cystoscopy, we must exclude the urinary infection with midstream urine and counsel the patient about the procedure. We must use sterile instruments and obey sterility rules, and use a lubricant anesthetic agent for, especially for local interventions. As we see, the AUA guidelines recommends no antimicrobial prophylaxis for cystoscopy. And the cystoscopy is a low-risk bleeding procedure. And we can continue aspirin and some other anticoagulant therapies for cystoscopy. I think the most important step for cystoscopy is to perform the cystoscopy with a bladder diagram. When we are performing the cystoscopy, we must examine the whole urethra, trigone, ureteral orifices, right and left wall, anterior and posterior wall of the bladder, dome, neck, and the posterior urethra. We can use rigid or flexible stethoscopes. They have some advantages and disadvantages. With a rigid stethoscope, they have a larger working channel, a greater instrument channels, better water flow, better and easy manipulation, better irrigation for blood clots, and it gives more pain and discomfort for the patient. For flexible stethoscopes, we can perform bedside examination and easily pass the elevated bladder neck. It has more deflection ability. If you are using a digital flexible stethoscope, it has greater image, but the hematuria and blood clots are problem because they have thinner water, instrument channels and low water flow. The rigid stethoscope units consist of a metal sheet, a bridge, an obturator, a lens 0 to 120, a camera, and a light fiber. Flexible stethoscopy units, we have both fiber optic and digital scopes. They are portable. They are very portable instruments. You need a camera head unit and a monitor. For ureteral standing, we need a radiolucent table, general, regional, or pseudoanalgesia, dorsal lithotomy position, flexible, rigid or a rigid cystoscope, a fluoroscope, a guide wire, a ureteral catheter, and radio-opaque media, ureteric stent. The first step of the ureteral standing is the retrograde placement of the guide wire. We must perform a cystoscopy, full cystoscopy, and locate the ureteric orifice. Then cannulate the ureteric orifice with a guide wire. We recommend a hydrophilic guide wire. And pass the ureteric guide wire to the renal collecting system with the fluoroscopy guidance. We can perform a retrograde pilocrime if necessary to visualize the ureteric anatomy. The patient's height is a more reliable guide to a ureteric stent length than a direct measurement. The most critical step of the cannulation of the orifice, we must care for an atraumatic entry. This is very important because we can do a false passage and it will be very problematic. We must always use a hydrophilic guide wire. If a false passage is created, a retrograde study can be obtained to visualize the ureteric anatomy. If the guide wire gets arrested in a false passage, we can use ureteroscope and try to see the opening of the ureter. If the stent is not sliding over the guide wire, the cystoscope should be kept close to the ureteric orifices. This allows us a more efficient transfer of force to slide the catheter over the guide wire. The guide wire should be held tight by the assistant to avoid looping in the bladder. This is very important. A tortuous or kink ureter may pose a challenge. We can perform a retrograde pyelography and use an open-end ureteric catheter and pull the guide wire to the kinks of the ureter and pull the ureteric catheter over the guide wire. An angled ureteric catheter or cochlear catheter can be used combination with hydrophilic guide wire under fluoroscopic guidance for tortuous ureters. If we insert a ureteric catheter, we must remove it, and sometimes it may be difficult. If your stent placed for a long time, if the plane graph shows minimal encrustation with a low stone burden, ureteroscopy and intracorporeal lithotripsy with a pneumatic or a laser lithotripsy can successfully remove the encrustated stent. Or we can do extracorporeal shockwave lithotripsy before the removal of the stent. This is another option. If we have a large stone burden, like in this plane graph, we must do a percutaneous nephrotomy or even an open surgical removal. The indications for semi-rigid ureteroscopy are we have both diagnostic and therapeutic roles. We can use it for ureteric stone treatment, diagnosis of hematuria, diagnosis of obstruction, ureteropelvic junction stenosis treatment, ureteric tumor treatment, and to diagnose the positive cytology. The most important step for a rigid ureteroscopy is the planning and preoperative imaging and correct site marking. We must have a fluoroscopy unit, specialized equipment and disposables. The AUA guidelines do not suggest antibiotic prophylaxis for diagnostic ureteroscopy, but for the stone treatment, guidelines suggest antibiotic prophylaxis. And rigid ureteroscopy is a low-risk bleeding procedure like cystoscopy. The steps of ureteroscopy, we must initially perform a full cystoscopy and exclude any gross malignancy and identify the ureteric orifices. And gently catheterize the orifices with a hydrophilic guide wire. The guidelines advocate the use of a safety guide wire. This is very important. We must perform a single-shot fluoroscopy to see the tip of the guide wire in the renal collecting system. And we must fix the guide wire to avoid it kinging and ensure that it does not accidentally get pulled out during any intervention. Once a safety guide wire is in place, this often helps us to keep the ureteric orifice open and aid the passage of the rigid ureteroscope. For difficult placement, we must do the steps like we talk about for ureteric stenting. As we talk, we must use first a hydrophilic guide wire for ureteric orifice catheterization. If you want to change the guide wire, we must do it with the open-end catheter. If difficulty of inserting ureteroscope due to a narrow ureteric orifice, we can use a balloon or plastic dilatators. If ureteral access is not possible, we may inject a double J stent and do the ureteroscopy after 2 weeks. I think this is a very good option. Before inserting the scope, the bladder should be emptied to avoid compression of the ureteric orifice and facilitate the scope advancement. If it is difficult to enter the ureteric orifice, the scope can be rotated 90 to 18 degrees, which can be compensate for the curved beak at its tip. The initial safety guide wire will keep the ureteric orifice open, and a second navigating guide wire can be added to widen the access for the scope. If the ureter is snug and the scope is not easily advancing, it's imperative not to force the scope as there is a high risk of ureteric perforation. Place a ureteric stent. In this situation, we can place a ureteric stent and wait for 2 to 3 weeks, or we can use a thinner instrument. Gentle manipulation of the ureter is very important for avoiding perforation and avulsion. Using a safety guide wire is very important to cope with complications such as perforation. And when we perforate the ureter, if we have a guide wire in the collecting system, we can easily place a double J stent. If you can't pass the obstruction with a guide wire, we can use the ureteroscope, bring it close to the obstruction. We can use contrast media and see the renal collecting system. If all these manipulations failed, and this is due to a stone, we can carefully fragment the stone via the ureteroscope, and we try to place the guide wire again. Ureteroscopy. In Turkey, we have our residents perform 100 cases of ureteroscopy. It looks like an easy procedure, but we have some important warnings. We must complete all required equipment. When advancing or pull out the ureteroscope, we must never too force the ureteroscope. The pulling out ureteroscope, we must pull out the ureteroscope with gentle rotating. We don't use balloon dilatation if really necessary. This is very important. And I think the most important thing is never work without a safety guide wire, and avoid blind basketing. This is very important for ureter avulsions. And another problematic situation is the ureteroscope trapped in the ureter. We have two manipulations for the situation. We must increase the irrigation pressure in the ureter, hence the ureter mucosa will be released from the ureteroscope, and gently pull out the ureteroscope with gentle rotations. And we can hold the ureterovesical junction from the rectum or vaginal fornix. And one of the most important factors is the clinical experience. Retrograde pyelography is used to visualize the ureters and collecting system. This procedure is performed with cystoscopy with an open-end ureteral catheter, contrast injection, and dynamic fluoroscopy image. The double ureteral catheter may be used for pyelography and the guide wire manipulations. Nowadays, we perform retrograde pyelography for percutaneous surgery, especially for percutaneous surgery. And the other indications are to evaluate the ureteral obstruction, to identify film defects such as stones or tumors, to assist the percutaneous access, to aid in stent placement or ureteroscopy, to evaluate hematuria, to evaluate trauma, to evaluate structures, to evaluate collecting system anatomy. Thank you.
Thank you, Tolga. Any questions? Ayşe? Microphone.
Since there are medical students among the audience, I want to ask only one question. Ureteroscopy is a challenging intervention during our daily urologic practice. I want to ask that what is the most challenging complication you have experienced during your ureteroscopy practices?
Yes, of course, the most challenging complication is the ureter avulsion. As in my presentation, I talk about it. The tract ureteroscope is a very problematic situation. For my opinion, do not force the ureter. If you have any problem with your ureteroscopy, put a double J stent and wait for 2 or 3 weeks and perform the ureteroscopy again. I think this is the most important step for avoid complications.
Tolga, I want to ask a question about related our meeting. You mentioned about the really basic endoscopic skills for urologists, maybe especially in point of many students. They are observing many cystoscopy, ureteroscopy also. And on Saturday they will perform these procedures.
Yes.
And what's your opinion about? Because I know that we together with many ureteroscopic cases and also many training on some cadaver sessions about the 3D printing. Do you probably this is also your first time to give training on 3D printing models? I just want to learn about your feelings about the positivity or negativity about the 3D printing basic endoscopic surgery.
Yes, I think the most important thing for education for endoscopic procedures, it's like a plane simulation. We must educate the residents with first with simulations, and the 3D modeling is very important for their education. If we train with the real patients at first, we see many complications. Also, I think the 3D modeling and the beginning their education with 3D modeling and simulation is the most important step of the endoscopic procedures.
Hello, Dr. Mili, and I want to add something. I want to add something that before performing live surgeries, the top level of learning curve is cadaveric dissections and cadaveric operations. But before cadaveric operations, the surgeon, the medical student, or the resident need to perform surgeries or learn the anatomy and learn the basic steps on 3D modeling and 3D simulations. So they will be familiar with the anatomic relationships, anatomic landmarks, so they will be prepared for live surgeries. Afterwards, they will go on cadaveric dissections and then live surgeries. But many residents do live surgeries from the mentors who they show them, but this is not correct. They will come to face with many complications, and they don't know how to solve the problems because they don't know the anatomical landmarks, relationships. So this is very important, the 3D simulations, 3D printing, and then which we perform with Dr. Huri cadaveric courses, and we invite all the people, all the surgeons, residents to attend the courses, and then they will be feel confident at the operation room. And we showed that at a study which we performed at our cadaveric course as a pre-test and post-test for throat surgery, and the result was that the attendants felt confident at the operation room after the cadaveric dissection course. Thank you.
Any question? Asha?
When you consider the learning curve of ureteroscopy in live surgery, what is your opinion about the number of cases that a surgeon has to apply to be sure that he has learned?
Yes. You know, the ureteroscope has both therapeutic and diagnostic interventions for, especially for stone disease. I think 50 cases is very important. First 50 cases, for my opinion.
Okay, thank you. We have 20 minutes cover break.